When we talk about the respiratory system and its primary purpose, which is the exchange of gases between the body and the atmosphere, we have to deal with how the body gets air in and out of the lungs, so the actual breathing mechanics. So in this section, what we're really going to be focusing on is what's known as pulmonary ventilation, the moving of air in and out of the lungs. The other three, external respiration, respiratory gases, and internal respiration, we'll deal with in the next set of notes. So when we talk about the mechanics of breathing, we are literally talking about the changes in the muscles, the contraction of the muscles, both the intercostals, which are the muscles between the ribs, and the diaphragm, and its role in how this causes the lungs to expand and contract. It is purely a mechanical process, meaning there is no, in terms of physiology, there's no actual chemical process taking place other than what's behind the contraction of the muscles. It depends on atmospheric pressure, which is huge. And this goes back to the very beginning of anatomy when we talked about the survival needs, and you have to have a pressure difference. If there's no pressure difference, we cannot cause air to come into the lungs or air to leave the lungs. So we have two basic phases in the mechanics of breathing: inspiration, where air goes in, and expiration, where air leaves. First up is inspiration. This is getting air into the lungs. What's cool is that it actually involves muscle contraction. So if you put your hands on your rib cage here and here, and you feel your rib cage expand when you breathe in, that's actually because the muscles are contracting. So the diaphragm is contracting, okay, it moves inferiorly, that's how it contracts, because remember it sits up here, so when it contracts, it actually pulls flat, and this actually causes, because of the pleural cavities and that link between the pleura and the lung. Here's my very ugly cavity picture, but remember that this, okay, is the parietal pleura, and here's my visceral pleura, which is on the lung itself. Okay, so this right here is my lung, all of this in here. Because of that fluid here, it helps to keep the lungs expanded against the serous membrane. That serous membrane then is going to move down with the contraction of the diaphragm and out with the contraction of these muscles between the ribs, the intercostal muscles, and that actually, because of the elasticity of the lungs, helps the lungs expand. That expansion literally changes the pressure inside our lungs, forcing air in. Okay, and so we've effectively increased the volume, which means we've decreased the pressure inside. And thanks to that decrease in pressure in the lungs, atmospheric pressure is greater, and it literally forces air into your body. It's the same thing that happens when you suck on a straw. You're literally removing air from the straw, and so now the atmospheric pressure on your drink is greater than what's in the straw, and that's what forces the fluid up into your mouth when you change the pressure inside a straw. This also means that expiration works in exactly the same way, just the reverse. So the diaphragm relaxes, that means it curves back up, so it's putting pressure on the lungs, forcing the lungs to recoil, or helping the lungs to recoil, I should say. The intercostals relax so that the rib cage drops back down, and you can literally, again, if you put your hands on the outside, you can literally feel that change in the size of the rib cage. And again, this makes the pressure inside the lung greater. And now that the pressure inside the lung is greater than atmospheric pressure, we force air out of the lungs. It's just like if you squeeze a sponge or squeeze a water balloon, that fluid movement is forced to change position, and that's exactly what's going on with the air in your lung. In general, when you breathe in and out, the inhalation is the only active part of the process. Expiration is typically passive, because as soon as the muscles relax, you're not really doing anything about it. The air just naturally leaves because of that change in pressure. We can force more air out, so you can forcibly force more air out of your lungs by kind of squeezing everything down and actively decreasing that area, but that's not something we commonly do. Now again, we said it was differences in pressure. This is both within what's known as the intrapleural pressure And well, let's back up. Okay, so first, when we talk intrapleural pressure, that's within the alveoli, which means what you should recall is that this is the very end. It's the actual location where gas exchange will take place because it's the smallest particle or the smallest sacs within the lungs that are covered by blood vessels, so it's where all our capillaries are for that gas exchange to occur. When we did the histology unit, this is when we were looking at the simple squamous tissue and how it seemed to form those little ball areas. Those ball circular areas were the alveoli. These are the air sacs. In the alveoli, the intrapleural pressure is always slightly negative compared to the lung and atmospheric pressure both. This negative pressure within the alveoli is in large part due to the fact that we have alveolar fluid. We have some fluid in our lungs. We talked about that in the previous section. And this fluid actually helps the lungs to recoil, and it helps the alveoli to occupy the smallest possible space. By the same token, it is opposed by the pleura, the cavity here, holding the lungs to the chest cavity. And so that pleura cavity holding the lungs to the chest cavity works just like if I put water between two pieces of glass. Anytime you look at that, it helps to hold them together. And that's literally what's going on. So this negative pressure exists partly because of the fluid within the alveoli, but it's opposed by the fluid dynamics between the lungs and the chest cavity through the pleural membrane. And so what this does is it helps to maintain a certain negative pressure, which makes it easier for air to flow into the alveoli. And so with changes in the size of the lungs, we get, with this negative pressure, that push in and out, which allows a certain exchange of O2 and CO2. Now, couple of points. Not all of our respiratory movements get air in or out, and that's where when we talk about coughing and sneezing, laughing, crying, yawning, hiccuping, those aren't necessarily moving air in and out for the exchange of gases. In addition, when we talk about the movement of air in and out, not all of your air leaves your lungs, and so you maintain a certain amount of air in your lungs at all times. When we talk about these changes in the volumes and the capacities, there are a few things that affect it. Your size in general, because that affects the overall chest cavity. Gender differences, so sex differences. Males typically have larger chest cavities than females. Females are typically just smaller, so the capacity for women is on average smaller than men's. Your age and your physical condition. Let's be honest, anybody that plays an instrument typically has a greater respiratory volume and capacity simply because of their ability to have to literally strengthen the muscles associated with it. And then usually, notice here, about 1200 is what stays in the lungs. Now we have different names for all of these things, so do not get thrown off by all of the acronyms. Now, when we talk about the what they call inspiratory reserve or expiratory reserve, we're literally talking about, okay, if you just breathe normally, air is moving and going, you can force more air in, okay, that's the inspiratory reserve. And typically speaking, that ranges from 21 to 3200, low end women, and the high end is men. Okay, and then expiratory reserve, so if you just sit and breathe, and then after you breathe in, you force more air in, that's this. The expiratory reserve is if you breathe and then you force more air out. And that's usually 1200 in men, it's actually 700 in women. So it's much smaller. And again, this ties back into the gender differences, which basically is going to tie back into the size of your chest cavity. Okay, there's a couple more to talk about, which would be residual volume and vital capacity. Now, when we talk residual volume, it's just the normal amount that tends to stay in the lungs. So this 1200 mils primary purpose is basically to keep the alveoli open. as we said, that there's fluid surrounding the alveoli that helps them to stay relatively small. And so without a certain amount of air there, they would literally just, in the same manner that our lungs stay attached to our chest cavity, the alveoli would start sticking together and close off. So if we didn't maintain this residual volume, our alveoli would not stay open. We wouldn't have gas exchange at all. Now, the vital capacity is basically the total amount of exchangeable air. Notice that the inspiratory reserve and the expiratory reserve are beyond the tidal capacity. Sorry, not the vital capacity, the tidal volume. So this is the amount I can inhale past the tidal volume, and this is the amount I can exhale past the tidal volume. Those three together are known as the vital capacity. The last one is this, what's known as the dead space volume. And in essence, it's just air that stays in the passageways that never really makes it down to the alveoli, never makes it to the actual gas exchange area. This dead space volume is usually 1 mil per pound of body weight. It just hangs out there, and it's kind of what keeps, even though thankfully we have hyaline cartilage in our trachea and all through our bronchioles, it's just the air that fills that area. The dead space volume can change with sickness or disease as some of the alveoli become damaged or closed off, or literally because of the amount of fluid end up closing and no gas exchange can occur. So ultimately, when we talk about the volume of air, we talk about how much we can breathe in, we talk about how much we can exhale, and then we talk about what's normal. And you can see how the tidal volume fluctuates normally. We can force more air in, we can force more air out, and this is what's known as our total lung capacity. And that machine, if you've seen it at the doctor's office, you usually have to breathe in and breathe out, and it fluctuates, and it actually measures the amount of air in and out. So this machine, when you inhale and exhale, the little dial in here will move up and down based on the amount you can force in or out, and that's what measures your lung capacity. That's the spirometer. The last thing is, anytime a doctor listens to you, what they're listening for is they're listening for the different sounds of the lungs. So the two sounds would be the bronchial sounds, which is just air rushing through the open spaces, and then the vesicular sounds, which are the soft sounds of air filling the alveoli. That's basically it for this section.